I'm going to hand things over to Dr. Leena Augimeri. Dr. Augimeri is the director of the SNAP, which stands for Stop Now and Plan model. She's a scientific and program She's oversees scientific and program development, and she's also the director of the Center for Children Committing Offenses at the Child Development Institute. And she and her team have really, as I said, done an amazing job. And she's going to walk you through, developing an evidence-based approach, evaluating it, implementing it, and then rolling it out. So, Dr. Augimeri, thank you very much for presenting today. I'll hand things over to you.
You're very welcome, Paul, and thank you everybody for joining us today. It's a real honor to be able to share what we are doing at the Child Development Institute, in particular the SNAP model. So my focus over the next 20 minutes, and there's lots of slides that I'm going to go through really quickly, but you will get the handout, is how measurement rocked our world and embracing a scientist practitioner framework within a community-based setting. And the setting is at the Child Development Institute, and the model is the SNAP model. I'd like to introduce first my colleagues that are with me here today. We have Margaret Walsh, Dr. Samantha Yamada, and Adam Donato, and they would be happy to address any questions at the end of this presentation. I want to thank Danielle for doing the land acknowledgement. I also would like to acknowledge that CDI, in which I work from, is situated upon the traditional territories. But what I would really like to say is, most importantly, I want to acknowledge our beautiful First Nations children who lost their lives as a result of residential schools, and that the lasting impact this has had on and continues to have on the lives of Indigenous children, families, communities, and this country. I'd also like to acknowledge all the children and their families who we have had the honor and privilege of working with, who continue to share their experiences and information with us. All our partners, whether it's government, philanthropic donors, foundations, business sector partners, but also our CDI SNAP team and all our SNAP affiliate sites around the world. But really would like to thank this committee who pulled together these vital series on measurement-based care, because I can't tell you enough, and you'll hear me stress it more and more throughout my presentation, we cannot afford not to do measurement-based care. So Ontario Health, the Mental Health and Addiction Center of Excellence, the Ontario Hospital Association, and the University of Toronto, thank you again. So I'm going to share who we are as an organization. We're an organization that has a multitude of different buckets within this children's mental health and multi-service type of organization. We have what we call children, youth, and family mental health and treatment services. We have family violence services. We have what we call healthy child development, which is where our early learning and daycares are. And we also have learning disabilities and mental health specialization. But what holds our agency together, and there's lots of things, but one of the core aspects at the Child Development Institute is what we call this scientist practitioner framework. And it has evolved over the years. But from the onset of SNAP being developed 35 years ago, this scientist practitioner framework, which was in place from the beginning, which is how does clinical and evaluation work hand in hand? And they really do go hand in hand as you start to build this out. And because we do that, we also engage in knowledge dissemination, as well as more recently in the last 2 decades, implementation science. But what I'm going to really focus on today is this bucket, which where SNAP sits. So SNAP or CDI has multitude of different clients they see in children and families. But part of our focus over the 100 years has really been children aged 6 to 11 in the middle years. And it says the forgotten group because up to 5 years ago, Ontario did not have a middle year strategy. And so a lot of focus was on 0 to 6, a lot of focus was on 12 and up, and rightly so. But somehow there was this lull. And these are the middle years, a critical developmental phase. And so that's why it was important that we push this needle. So when I talk about how do we bring a measurement-based care into our work, it really is to improve what we do. And so when we think about service delivery. And this is what it is. It's service delivery. How do we ensure we're making a difference in the lives of children and families, apply empirically supported treatments, scrutinize our own work because we should be doing that ongoing. And the why is so that we can do the best possible service, improve clinical practice, advance the field, and really be accountable. And accountability on all levels, to ourselves, to our organization, and most important, to our clients. And so therefore, it's really about this assess our program results and act on our findings that I'm going to share with you as I go through the presentation, how we actually do that and how measurement-based care plays a vital role in this. So when we think about measurement-based care, and I love this, someone gave me this as I was doing training one day, and as a thank you. Measurement-based care can seem insurmountable. It can seem hard, but it can seem impossible or not. But it is absolutely possible, and we cannot afford to not do it. We just need determination. And when I start to tell you this story about SNAP and how we built in measurement-based care from the beginning, we did it because, as you'll see from the evolution in a few seconds, we started it because we knew that evaluation was critical to good clinical care. And so we used measurements from the onset of the SNAP program when we developed it 35.5 years ago. And we used measures such as the CBCL with parents and caregivers, the teacher report form with teachers and educators. And all this information was then presented at the client's case conference, where the parent and caregiver was part of the development of the treatment plan and formulated based on the child and family's level of risk and need. So from the onset, everyone, including the parents and caregivers, the children, the clinicians, and the evaluators, were involved and contributed to the information and treatment plan. And that, I feel, is the essence of measurement-based care. So sharing a little bit of our journey. So what ended up happening is in 1984, Canada made a great move. They decided that they needed to move the age of criminal responsibility from 7 to 12. 7 to 12, because kids as young as 7 could be charged earlier. And so at that time, there was a bit of an outcry that there were lack of services. There weren't really services. So there was a gap. And how are we going to fill this gap? So given CDI's expertise in working with kids in the middle years, we felt that we were well suited to start to look at how we can fill that gap. And by doing so, we started to look at the literature. We started to review the scientific literature and look at what worked, what didn't work, what were considered best practices. And as a result, we started to create the program, and we formally manualized it. And one of the key things we did right from the beginning is we engaged in fidelity practices. And as a result, that's how SNAP was born. So SNAP stands for Stop Now and Plan. It was established, like I said, in 1985. It is today an evidence-based trauma-informed gender-specific model. It was not when we first started. We had to build the evidence. It teaches elementary school-age children with disruptive behavior problems and their parents and caregivers how to stop and think before they act and make better choices in the moment. And the proven impact, if done right with high fidelity and integrity, we know it can improve disruptive behavior and increase self-control. We can sustain change. We can reduce crime, we can be cost effective, culturally responsive and safe, and build healthy communities. And the core nugget of SNAP is the strategy, which is helping children identify how their thoughts, feelings, and actions are all interrelated, teaching them how to identify body cues, identify hard thoughts and change them to cool thoughts, and come up with plans that are going to make their problems smaller instead of bigger. And based on this, the theories within a developmental framework are cognitive behavioral, attachment-based, social interactional learning, a feminist perspective, and a systems. And it's also based within 9 core principles, as you can see. Everything from the scientist practitioner model to collaboration to client-centered, and it goes on and on. The other aspect, which was core throughout this, was the evaluation process. And as you can see, from the technique to the program to the principles to the theoretical underpinnings, it was the evaluation component that really got us moving. And as we developed the program, this is what we call our process measures and flow chart. As I indicated right from the onset, from inquiry to screening to assessment to treatment to discharge, there is a process that happens and there is measurement that happens. And as you can see, each piece of this information feeds into and builds the case file and builds the information process so that we can ensure that we are doing the best possible service based on the child's level of risk and need. And so you can see that every single part, whether it's inquiry to treatment to discharge, links to specific information that we collect. So as you can see that as we started to build this program and we started to engage in evaluations, we started to note that we were actually making significant differences in our pre-post assessments, which then led to more stringent type of evaluations like quasi-experimental, randomized controls, and longitudinal. Not that everybody has to do this, but it did push us in that direction. And as a result, this continued to grow and grow over the last 35 years. And as a result of the research and evaluation conducted, we are able to know what is it that we actually do well in and target. We're actually able to decrease externalizing behaviors like aggression, rule breaking, irritability, you see that on the screen, and increase self-control, emotion regulation, problem solving, executive functioning, and even parent-child relationships. So the big question, how do we build a culture of measurement-based care? Well, we built it right from the onset of having established what we call the scientist practitioner approach or framework. It is part of our core SNAP principle. It is also part of CDI strategic goals. And it was an investment that we did from the onset. Whereas when we hired three people were hired to start the SNAP program. There was a child worker, there was a family worker, and there was a researcher, which was my position at that time, right out of my undergrad. So we need to really try to think about is when you're doing measurement-based care and building this culture, you need to kind of think about what is working, what may not be working, and how does that measurement help you do that and determine that in order to provide the best possible services for your kids and families. So we also look at identifying service gaps, and I'm going to go into the URL in a second to show how that tool was developed to help identify level of risk and need. We also continually build our network, whether they're scientists, clinicians, policy educators, to help us learn, to help us improve, to help us do what we're doing better. We participate in conferences and learning forums, and we also do things with our team and the agency like brown bag lunches, which is reviewing articles, having stimulating discussions with staff, reviewing findings, and then of course, as I said earlier, engaging in fidelity monitoring, which is critical. And I'm going to go through that in a second of why that's important. So a natural integration of evaluation and measurement into clinical practice is absolutely doable, feasible, and needed. And what is important is when you think about that, you have to think about weighing clinical and evaluation and implementation and fidelity, because that is the key to good, being able to scale and implement good programs. So I talk about fidelity. So fidelity and adherence was something critical from the beginning. When we started the program, we were just one site. We were in Toronto. We were at the Child Development Institute, it's formerly Earl's Court, and we ended up saying, okay, how do we ensure that our clinicians and our facilitators are actually trained and also ensure that they are implementing the program the way it says in the manual? So we created these adherence checklists, and we would be behind the mirror and we would watch the sessions behind a one-way mirror, and we would complete these forms that looked at everything was the room prepared? You know, are they following the different components of the manual, and what would be the rating that they would get, and any kind of notes that would enhance that. And that helped us look at linking good adherence to outcome. So that was really important, which is good adherence, does that lead to good outcome? The other thing, as we started to progress and develop, we realized that one of the things that was different from adherence was competency skills, which is what is the competency skills of our facilitators? And how do we enhance what we could be doing to support their learning so that we can also ensure we get the best possible outcomes. I don't know about you, but when I do training and I'm in a group of room, I can tell. I would come back and I would say, gosh, I knew right away which ones were going to be successful, which facilitators would be successful, and which would not. And Mark Walsh, our researcher, would say, well, how do you know that? We need to quantify that. We just can't say that, right? Because we need to figure out how to quantify that. So we started to develop these competency ratings, and you could see their general therapeutic skills to kind of more SNAP specific skills to behavior modification type skills and time management. So these were all really important. So when we think about measurement-based care, when we think about it, it forms individual treatment planning, enhancement to model and service delivery. It can demonstrate impact and cost effectiveness, which also leads to policy changes, helping to get programs designated as evidence-based, and program scaling, which equals more impact. And sometimes when we start, we think there's a clear path that goes just straight ahead. We're going to do this, and that's great because you want to be positive. You want to have your cool thoughts in your brain and realistic. But the reality, sometimes it is not as clear as we think. So there are challenges, and challenges start with there needs to be resources to be able to do this work. As I said from the very beginning, a researcher / evaluator was built in to this very small program that started with 3 staff. One was a family worker, child worker, and one was an evaluator right from the very beginning. And that built the culture of the scientist practitioner framework. We need buy-in, and buy-in needs to be everything from your board to your senior leadership to your team to your entire organization. And there's an issue of lack of trust sometimes in the process when you do measurement-based care, because a lot of times we'll get, well, what is it being used for? And so it's not about just collecting measurement for the sake of collecting it. It's collecting measurement first and foremost for treatment planning, and then secondary use is for outcome monitoring. And so a lot of times you have to build that understanding so that staff don't feel that, well, you're evaluating to see that I'm doing okay, or is it you're evaluating for some other purpose? So it's really a process of building trust. There's also about complexities. Every agency is different. Every applied agency setting is different. So we have to think about the individual complexities that go along with that. And then competing priorities of clinical needs. We hear about measurement fatigue, for example, in the previous presentations. So we really have to invest in measurement and practice. It's not one or the other or competing. It has to be seen on the same even playing field. And it's again about leadership vision, shared values, expertise, diverse stakeholders, funding, and any kind of ethical issues you may have to deal with. So early keys to success for SNAP really had to do with prioritization, commitment, and investment from leadership. So the ED at the time who hired me had this vision of we need to do this and we need to do it right. And we need to be able to determine that we are giving our kids the best possible services and their families. So the scientist practitioner framework was developed right from the onset. Measurement was to determine what are the risks and needs and to ensure best practices. It was based on collaboration, ensuring a learning culture, and building university partnerships. And the forward momentum piece is really, if I had to give you any advice, just start. Just start using measurement. Based on what you're targeting, you can use logic models, measurement and process flow charts. I'd be happy to share ours. You can start measuring to determine what is working and not, and just start small and don't be afraid to think big. So gradually work towards more sophisticated measurement. And what we did was we established this barometer to help us track and guide our process. And really the barometer tracked things like program planning, things like using a logic model, lit review, to having manual and fidelity pieces, to process evaluation pieces like do you track referrals, admission criteria, utilization rates, cultural competency, to more stringent from everything from client satisfaction to pre-post, and you can see all the way up to cost benefit and implementation science. So when we started this process, this is our SNAP's Comprehensive Children's Mental Health and Crime Prevention Framework. We started with the SNAP program, and over the years we evolved based on our measurement, based on our understanding, based on client needs. We knew we needed a better way. Even though we were using standardized measures, we didn't have anything to assess level of risk. And so also this referral protocol of how to get kids to the door. But I'm going to focus here because I'm realizing I'm getting out of time here. So I'm going to focus here. So the EARLs were our structured professional judgment that help us to assess level of risk and need in our clients. And really, they were developed to fill that gap in our understanding of which kids needed what and why based on their level of risk, which helped with dosage. And I love this saying by Pia Ennebrink, a colleague in Sweden. She says, qualitative findings suggest that the tool was especially helpful in providing clinicians with a thorough assessment process, a guide to gear the treatment interventions, and a barometer to evaluate whether a child was still considered high risk at post-intervention. So really, it's about how measurement leads to findings and how findings lead to improved service delivery. I'm going to finish with these last few slides, which is an example of exactly how that works. So in one of our pre-posts, we were realizing we were really doing well with our measurement-based care. We were using the CBCL, we were using the EARLs, for example, and other measures. We realized we were really doing well with our low to moderate risk kids. This is 70, which means on the CBCL, that means you're doing worse than 98% of kids your age. So there's a clinical cutoff. You can see that the kids who receive standard care seem to do okay for the moderate to low, but the high risk kids were not. But they seem to do better with this enhanced care. And that was my question. Are none of the kids doing better in the highest risk category? Like the highest risk category? And we realized that there was. The kids who ended up getting individual counseling and befriending actually did better. And so I'm going to show you what ends up happening. We also found out from another one of our studies is that one item on the child behavior checklist, cruelty, meanness, and bullying to others, predicted future offending 2.5 greater probability. And so as a result, we are now able to make upfront treatment recommendations based on standardized measures. And raising the bar even further, we developed a system. And the system not only helps us with scaling, but helps us do good program delivery and analysis and reporting, and helping all the SNAP sites do the same thing and build a culture of measurement-based care. So it's everything from pre-implementation to implementation to case management and an evaluation portal. And I'm going to go a little bit faster because I need to end. There's also a video portal where all the sites will, this is to do the good fidelity monitoring and evaluation, which is they insert their videos into the video portal. We evaluate them, we give them a rating, and we look at adherence as well as competency skills, which is excellent. So this is the system that we developed, the SNAP implementation tool, which is, it helps us automate all our evaluation processes. So all the standardized measures are in the system, and as a result, they're easy to rate and use, and you don't have to do data entry and all these other things. So here's a finding. Remember this, the highest risk kids and the kids who are on that one item, the system creates these reference guides. And Adam and Mark could answer any of these questions for you. And in this, all the information that we collect, whether through the child interview or the case conference or views and expectation of treatment or the EARLs or goal setting, they continue to implode and fill in and create these reference guides. And as a result, we're able to now create these information pieces that the system is able to help the clinician tell you which kids should get, for example, individual befriending as part of their treatment plan. So what it does is it pulls together this, which are the items on the EARL that were flagged, the one CBCL item, and if you get a total of 8, you then are automatically assigned a special friend, like an individual befriending and mentoring. And then it also provides the clinicians with these great evaluation clinical summaries from time 1 to time 2, which is pre and post, and which is moving in the right direction, which is changing, which is not changing, so that they can look at good treatment planning. So I'm going to end with this, that a few key points, measurement-based care, it is possible. It is possible. And you need commitment from your top, and engaging practitioners and scientists in the process is critical. Feedback mechanism needs to be in real time. You can't collect this information, measurement, and then have clinicians wait for it. It's just not going to work. As demonstrated in SNAP-IT, it can be really effective when it happens because it feeds the clinician immediate real-time data and what would be helpful clinically. And building a supportive network, we just can't afford not to engage in measurement-based care. I love this quote, without data, you're just another person with an opinion. So leaving you with this thought, each of us can really make it sure that children and youth and families get the best possible and available treatment. Focus on what works. We can do better. Kara Minden. Let's raise children who won't have to recover from their childhood. And Pam Leo. And as a result of that, we cannot afford to not engage in measurement-based care.
Don't forget to use your SNAP.
Thank you.
Thank you very much, Dr. Augimeri. That's 35 years of program development in 20 minutes is an impressive feat.